Morning, everyone. Today I'm going to present the ECG case. This is our today ECG.
I'm sorry that the microphone is too far from her. And probably the right side of copy is the best place. Go ahead.
Good morning, everyone. Today I'm going to present ECG case. This is our today's ECG. Okay, who will start first?
Who will take it first? Traditionally, the people who closest to the screen.
And just doing a bit with capacity to move that it could probably be upper to the apex. Also the lady lead one is active, it seems probably the left to right. Also there is the no definite P wave preceding the neutralized conflict, so maybe that may be the junction.
So you mentioned the wide course rhythm, course complex,
Yeah.
such as PBC.
Yes.
What evidence do you read it? Okay, so generally the EP physicians are short-tempered. So we have a rule. If somebody has quiet for 5 seconds, let's move to next people. Okay, Dr. Zhang.
I think after 2 bit, I cannot find P wave anymore. So I think there's a problem at node function, I guess. So
Sinus node dysfunction.
yes,
you mean?
yes.
Okay.
I think something happened to patient. So, and secondly, I think I can't find full P wave at node, V4 to V6. So I think there is a maybe electrical abnormality for patient and or myocardium dysfunction, I guess.
Because the whole TWAV be 5-6, you mean?
Yes.
Okay.
Yes.
Okay, so when you try to interpret the ECG, it's better to watch forest first, backside seat. And if you watching the rhythm strip, how is it? There is 4 beats are grouping. You can grouping the 4 beats, right? Tang, 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 tang. We call it cardiac ballet. Okay, there is some grouping and regular the pattern of ECG rhythm. Okay, then you can come inside one by one. Okay, Washim.
So
How do you think about this cardiac ballet?
So, as Professor Park mentioned, there's a pattern in this ECG of 4 beats together with different morphologies of QRS. So let's go over each of these beats. If we look at lead 2, let's start from the third beat. The third beat has in lead 1 a normal looking P.
So could you follow with mouse? Yeah. No, you. Oh, okay.
Let's start from this beat, and then in this beat, in lead one, we can see a clear P wave and a normal looking torus.
Mhm.
So this might be a sinus beat. And after this sinus beat, there's a pause and the junctional escape beat comes. After this, the next sinus beat conducts with an RBB aberrancy. This may be because of an Ashman phenomenon because of long short sequence.
Okay.
And after that, there comes another beat, but the P wave is not very clear. Is it a sinus beat coming at its own time and a deformed P wave deformed by the QRS of the previous beat? And then there's another beat which has again a different QRS morphology, this P wave morphology, and the same pattern repeats. After this beat, there's a pause, junctional escape, Ashman beat. Is this a sinus beat or is it an APC? I don't know. And then this looks like a sinus beat.
Mhm.
So, sinus beat, junctional escape beat, Ashman beat, probably APC, again sinus beat, and this pattern repeats.
Okay. Very good. And anyway, the first beat of narrow QRS complex is not preceded by P wave, so it looks like the junctional escape beat. And as Dr. Zhang mentioned, this patient has a significant sinus node dysfunction, but the following three beats may be preceded by P waves. I don't know it is the sinus P wave or ectopic P wave or non-sustained atrial tachycardia. Anyway, three consecutive beats are preceded by P waves. And then why the second beat is changed to be wide QRS, and what she mentioned about the Ashman phenomenon. Kofi, I always give you a tough question. Can you explain the mechanism of Ashman?
Okay, the refractoriness of the conduction system depends on the baseline heart rate.
Mhm.
So when you have a long RR interval, that gives a prolonged refractory period. So if the next beat comes earlier, then it comes during the refractoriness, commonly of the right bundle, and therefore it will conduct across the left bundle as a right bundle branch block, and that is why it appears broad. So that's the Ashman's phenomenon.
Okay, that's right, exactly. So the normal electrophysiology is bradyarrhythmia, prolonged refractory period. Okay, so preceding long hour interval, the prolonged refractory period, and also the repolarization heterogeneity, and following premature beat generate a partial and functional conduction block, make the bundle branch block pattern. Okay, then which bundle branch is blocked here? RBBB and the left here posterior vascular block pattern. So which bundle branch?
Oh, it looks like a right bundle.
I erroneously already told the
so-
answer.
So it could be bifascicular,
Yeah,
a bifascicular block.
right bundle and left posterior
bundle.
vascular
Yeah.
were blocked by Ashman phenomenon. Okay, so Dr. Chair, I'll ask again. Is this the PVC or the aberrancy? Aberrancy? If you keep continue to insist PVC, I can ask voting. Okay, then please summarize Dr. Zhang. All interpretation of ECG, and please imagine the cardiac condition of this patient. We don't have any information about the age, sex, and what kind of structural heart disease, but please imagine.
the patient had a long sinus pulse about 2 seconds, and there the maybe the second bit from
Yeah,
the
mouse. Use mouse.
I think it could be the PAC, but the wave is quite large, and so I suspected that it could be the patient with long AFib with the sinus node dysfunction, and maybe related to the arterial enlargement. So I imagine that this is patient may have the long-standing AFib. So the sinus node has a dysfunction. And other.
Are you sure this patient has long-standing persistent AFib? You may know some history of this patient. Nobody knows that in this room, I guess.
I can see it's just the side. It doesn't show the AFib rhythm, so it's hard to say this patient has a permanent AFib. But I just get
No, please give us the evidence. How do you determine this patient has a permanent atrial fibrillation?
no. This is not the AFib, so it couldn't be the permanent AFib. I just thought that the P wave looks very large, so that's why I guessed like that. And the sinus node dysfunction is common in the AFib patient. So, except that I agree with all the prior opinions.
Okay, now give me a mouse. Let's summarize the result. You can notice there is a group beating, and the first one didn't show any P wave, so could be junction. And the usual junction rhythm shows the little different QRS morphology compared to the sinus conducted or AP. You can compare this V1, comparing this one and this a little different, right? Because junctional rhythm is narrow QRS, mostly narrow QRS, but the activation sequence a little different. The sinus AV node conducted QRS. So, and it is junction, and I don't know, I think it's overlapping with P wave and T wave. So I don't know which from which to which portion is P wave. Anyway, P wave generated wide QRS because function upon the branch block. Washington mentioned about it, the Ashman phenomenon. And how about next beat? Still there is some notch, right? So this means it is also, I don't know, it's the same P wave or another active peak. There is the conducted QRS, and the other one also shows conducted QRS. Okay, so I think that this patient has significant sinus node dysfunction, and probably some associated atrial arrhythmia, even though it is the escape beat. And based not only the P wave and the arrhythmia rhythm, if you look at the narrow QRS, limb lead axis, and the precordial lead axis, is pretty normal, right? And I don't see any significant cardiomyopathy pattern. So the LV function could be relatively normal in this patient. And Dr. Om, your comment?
I wonder this P-wave interval is regular or not.
Can you measure it on the screen?
Probably.
No, you don't have a caliper?
Yeah.
Caliper and stethoscope is a basic weapon for a physician. Regular or irregular?
Regular. Almost all. Regular.
Regular.
Repeat.
Sure? Are you sure?
Yeah.
We don't like the terminology, but almost.
I have regular.
Right.
Regular. Okay. So
So three consecutive QA groups were written. And it probably the origin may not sinus written because the QA morphology is different from sinus QA. So I think the functional, basically functional rhythm and very non-sustained, I mean 3-bit HR rhythm. HR rhythm. Almost 100. Yeah. HR traits is almost 100. Another, I would like to say it's what if this one noise or PUA? I'm not sure. Probably noise. There are no PUA before this rhythm. I need this one.
if it is real P wave,
Yeah.
some patients shows this kind of rhythm after major surgery. After major surgery, the surgeon cutting down the atrial tissue. So the P wave is very, very, very tiny voltage. Sometimes we cannot notice it. The only way to determine is P wave or junction rhythm, but you can hook up the atrial epicardial pacing lead to ECG machine. Then you can determine this P wave or real sinus pulsing junction. I didn't notice it. Dr. mentioned a very important point. Okay, any other comment?
Dr. Ball,
Okay.
can you hear me? Good morning.
More information.
Okay. Patient is 63 years old male, chip compare with complication. The patient has history of open mitral commissurotomy in 1984 for severe mitral stenosis and underwent radiofrequency ablation for focal AT in November 2025. He also underwent double wall replacement, tricuspid anorthoplasty, and he is currently on the following medications. And the patient's initial rectum was actual flutter. First, I showed the SDG is patient same day after and chest X-ray cardiomegaly echo is normally 59%, and also depth actual enlargement size is 85 millimeters. And complexity shows material stenosis of mid LAD. This is the targeting point. Radiofrequency ablation was performed targeting the CDI and the right atriotomy scar to the IVC. This is the patient's follow-up ECG at 1.5 months. There is also can see the peripheral you can see in this. There is also can see the little notch, bigger notch.
So you want to interpret this ECG? Okay, let's start from Dr. Gang. Because we have the international conference at 9 o'clock. So, please.
The pattern is similar here. This could be the junction bit, and this could be the Schumann bit. And maybe this could be sinus or PhD. and this is the junctional bit because I cannot see the P wave, and I suspect this could be a PAC, but it seems like not conducted. And after that, the P wave it seems regular. It has about a rate of 75 to 80. And the interval from here to here is different. So maybe this could be non-conductive APC and this could be the sinus rhythm. It keeps going on like this. So in summary, the patient still shows the junctional and the group bit, but I guess the patient also shows some sinus rhythm in the later part of the ECG.
But why the initial RR interval narrow curves, fifth beat, fifth? Yeah. If it is junctional and escape APC, non-conductive APC, how come the RR interval is so regular? Booster? Copy or watching? Anybody?
So you mean this beat?
Yes. RR interval is very regular, right?
Yes, it's regular like the normal rate. This is clearly from here on. It's clearly a sinus rhythm.
I think so.
This could be junctional with a retrograde P,
No, retrograde should be negative.
or junctional.
If it is a retrograde P, the PA polarity should
in
be
inferior leads.
yes.
Yes. Or so then it's likely junctional, and then as suggested, an ectopic that was not conducted. This is definitely a focal ectopic P wave, not a sinus P wave.
Right.
I'm not sure why this falls perfectly in line with the sinus rhythm, because this is likely a junctional escape, and so I would have expected a different rate. So I'm not sure.
Okay, question.
See this PP interval, this and this, and this and this. Is it? It looks equal. So it may be possible. It's possible. And if you see the this ST segment here and ST segment here, there is this definite arm bump on this, which is not in other ST segments. So it's possible that the time that this junction came, this sinus also came. Sinus P wave came, and but because it was still recovering, it did not conduct. So maybe because this PP interval is same as this PP interval.
It's shorter. That PP interval
calipers.
is about.
So it is either a sinus beat which came almost immediately with the junction beat, but found this refractory and did not conduct. Another thing I want to point out is that the P wave is notched, and the terminal deflection in V1 and V2 is very wide and deep, evidence of LA enlargement.
Yeah, but still, I don't understand why the RR interval is so regular. Yeah, I agree. The some hump overlapped with ST segment is P wave and the non-conductive APC, but why the QRS is regular? Any idea, Dr. Wang? I wonder Dr. Cheng Huang is here.
I'm here.
Oh, he's here.
Oh, good morning, Professor Wang.
Morning. How are you?
Yeah, very good. We are waiting for you. Your
So,
voice is very small, so could you please speak a little closer to your microphone?
yes, I got the microphone here. Can you hear me or no?
because we have only 5 more minutes.
So,
International
It's better.
EGM Conference.
It's better now.
Yeah. Oh, it's better. Yeah.
okay, anyway, you cannot say evidence that this regular rhythm that you see bottom line is a sinus rhythm. Do you have what evidence do you have that after junctional rhythm, some PAC, and then you start this regular rhythm? So what are the possibility besides the sinus rhythm? Somebody who had a multiple procedure surgeries. So clearly 6-sinus syndrome, multifocal PAC happening, and then this particular coupling PAC triggered this regular sinus rhythm looking thing. Okay.
Right. Yeah.
So differential diagnosis is what? The PAC might trigger very slow atrial tachycardia.
Could
You
be.
you cannot exclude that possibility. That's why it's so regular. Second possibility is that maybe there is a sinus node reset, but I don't think it is because the coupling is too short. Now, if you look carefully, the preceding 3 complex, how many P wave do you see there? At least 3, I see.
Yes.
So that means this patient has a multifocal PAC or multifocal atrial rhythm, probably acting as a cardiac ballet. And the last conducted bit, that very short PR. You see that? The last one. Yeah, that one has very short PR. You're assuming that that probably came through, close the conduction system or a septal area somehow, somewhere around that area, which likely maybe result in more junctional rhythm. So I don't think we can say that this, based on this ECG alone, this is a sinus rhythm. You only can say the regular supraventricular rhythm, probably atrial rhythm, but I cannot rule out the PAC trigger ectopic atrial tachycardia versus reentry. But I would do favor for reentry because it's so regular. Okay. Otherwise, you do not explain why this patient heartbeat all over the place from the beginning. Okay. So he having some PAC is different coupling as well. Yeah, because after all this mitral valve surgery, all those ablations you guys did, I think that still have some issue.
Is this patient undergo the Maze surgery also?
Yes, I found some notes separating maids.
Maze.
Yeah,
Okay.
that's one
Yeah.
note.
That's why the P wave amplitude was small. So is there any other possibility that the junctional rhythm, the narrow QRS looks like junctional rhythm is preceded by very, very low voltage sinus rhythm after Maze surgery, and a small P wave preceded by first junctional like narrow QRS reset the sinus node and also induce the slow atrial tachycardia?
The way I see it, that if you look at the very first bit, the junctional rhythm with the P, but why don't you look at the P wave, and then look at the number 4 bit. There's a junctional rhythm with the P. First of all, coupling is slightly different, PA morphology is different. So this patient has multifocal PAC going on. So I do not know whether your argument is that sometimes P wave is so small and scarred, you cannot see it, is possible. But very unlikely because you can see so many different variety of P wave axis, so you still see there's some activity. So I think probably the junctional rhythm in view of patient with 6-sinus syndrome, most likely. Okay. And as you said, your junctional rhythm may be QRS complex slightly different, perhaps, and but it's not very clear in this tracing here. Okay.
Okay, thank you very much. I'm happy to listen your straightforward and clear interpretation, and I think it's time to move to International EGM Conference. Thank you very much, Umdari. 이거 저거 뭐 recording stop. 대용 Kim, let's start.
Okay, we'll start the International EGM Conference.
대용 Kim will introduce you.
Good morning. Actually, I lost my voice. And today, Min Dong-che will present some case which will be discussed by Dr. Riz Chandra from Cambodia. Oh, please, Dr. Che.
Okay, I will start the EGM conference. The 37-year-old male presented with palpitations. He had a recent episode 1 month ago with a similar episode about 3 years prior. The symptoms were characterized by sudden onset and spontaneous terminations. He had no significant past medical history, and echocardiography showed structurally normal heart with the normal EF. And this is the baseline ECG. And this is the previously documented narrow QRS tachycardia. The chest X-ray was normal, so we performed an EP study. And this is the baseline catheter positionings at the RAO and LAO view. So tachycardia was induced, tachycardia with the eccentric atrial activation sequence was induced during the catheter positioning. So when we gave the ventricular extra stimulus, V-reset was observed, which means that participating of the ventricle in the circuit. The tachycardia cycle length was the 442 milliseconds. So we gave the ventricular overdriving pacing at the 421 milliseconds. The tachycardia was well entrained, and the VAV response was observed, and PPI minus TCL was the 101 milliseconds. Tachycardia was terminated during the V pacing, so tachycardia cyclings was 442. So we did cyclings was 847 and AH interval 75, HV interval 43, and QRS duration was 88. During the rapid ventricular pacing, the earliest atrial activation was observed at the HIS. VA block cycle length was observed at the rapid ventricular pacing 320 milliseconds. VA decremental property was observed at the rapid ventricular pacing. VA conduction was shifted from the AV node to the accessory pathway during the single V test. And VA decremental property of the accessory pathway was not observed. Accessory pathway ERP was observed during the single V test 600 to 120 milliseconds. And VERP was observed at the 600 and 200 milliseconds. And this was during the rapid atrial pacing. AV block cycle length was observed during the rapid atrial pacing 320 milliseconds. AH jump and the tachycardia was observed during the single atrial extra stimulus test 600 to 310 milliseconds. During the tachycardia inductions, intermittently AH intervals and the tachycardia cycle length was changed. This indicated that the different AV nodal pathway was being utilized. So tachycardia cycle length was 468 millisecond, AH 261, HV 54, and QRS duration was 84. And this is the surface ECG during the tachycardia. So when we go down to 600 and 280 milliseconds, retrograde conduction through the accessory pathway made the first echo beat. And after the first echo beat, there was the 2 echo beats with the concentric atrial activations were observed, but not sustained. The slow pathway ERP was observed during the 600 to 140 milliseconds. So in summary, the first tachycardia showed the narrow QRS tachycardia with the eccentric atrial activations, and the earliest atrial activation was at distal CS, and reset was observed, and during the entrainment, VAV response was observed, and also the PPI minus TCL was the 101 milliseconds. These findings were consistent with the orthodromic ABRT with the left rotor accessory pathway. And also the two echo beats with the concentric atrial activations, or the earliest atrial activation at the HIS, and the VA decremental property was observed. And during the single A test, there was the AH jump with the two echo beats. So these findings are consistent with the dual AV nodal physiology. So we performed the ablation targeting at the left rotor accessory pathway, and this was the ablation catheter positioning. Before starting the ablations, the earliest atrial activation and shortest VA interval was observed at the ablation catheter during the V pacing. So after the confirming the site, we starting ablations. And during the ablation, interestingly, a different tachycardia was induced. The first APC triggered by the ablation catheter was conducted through the AV node through the fast pathway, but the second APC, also coming from the ablation catheter, was conducted through the slow pathway, and it was induced the AV-NRT. So also, during the tachycardia, there was a PVC, but it did not influence the tachycardia, which also can be a clue for the AV-NRT. After the first ablations, when we paced from the V, accessory pathway was still remained. So we repositioning a new decapolar catheter to the distal CS. So pacing at the CS distal, still remaining the retrograde conduction through the accessory pathway. So before starting the ablations, we confirmed the target site by the CS distal pacing. And we started the second ablations. We performed after the second ablation, there was no retrograde conduction through the accessory pathway anymore. So after the ablation of the accessory pathway, we performed the induction test again with the use of isoprotenolol. And the second tachycardia with the concentric atrial activation was induced with the AH jump during the double atrial extra stimulus test. The tachycardia cyclings was 360 millisecond, age 336, HV 48, and QRS duration was the 75. And this is the surface ECG at that time. So in summary, during the first EP study, the orthodromic ABRT was easily inducible, and only the two echo beat was observed. But after ablating the accessory pathway, with the clues of AH jump and the tachycardia induction during the double test, and the VA decremental property, and the earliest atrial activation at the HIS during the V pacing, AV-NRT was also induced, so we plan to ablate the slow pathway too. So this was the ablation catheter positioning. After confirming the slow pathway potential, we did the slow pathway modifications, and there was the junctional rhythm during the ablations. So after the ablation, no further tachycardia was induced. And this is the final ECG after the ablations. So I bring some article, and this case highlights that dual AV nodal physiology is relatively common in patients with WPW and can significantly influence the tachycardia manifestations. Clinical presentation may vary, including the AV-NRT only or ABRT only, or coexistence of both. Importantly, ABRT is not a fixed circuit, but may depend on either the fast pathway or the slow AV nodal pathway. From a diagnostic perspective, a detailed EP study is essential before ablations to avoid the targeting the clinical insignificant APs. And the AH interval is a useful indicator for the AV nodal conductions. AH interval over 180 milliseconds suggests a slow pathway conduction. Additionally, cyclines alone is not sufficient to distinguish AVRT from the AVNRT, as the slow pathway dependent AVRT can mimic the AVNRT. In selected patients, AV nodal pathway ablation may be considered as an alternative strategy, particularly when the AVRT depends on the slow pathway, and the accessory pathway is not clinically significant or difficult to ablate. In such case, slow pathway ablations may be a simpler or effective options. However, routine slow pathway ablation is not recommended, particularly in the patient with the dual AV nodal physiology but without the clinical tachycardia. In conclusion, this case demonstrates that AVRT is not a pure accessory pathway dependent, but is significantly modulated by the AV nodal physiology. So careful EP study is essential for the accurate diagnosis and appropriate treatment strategy. Thank you.
Thank you, Dr. Chen. Dr. Chandra, please.
Thank you, Doctor, for your
Mine.
excellent presentation. I have a question for the patient. During ventricle pacing, did you perform the differential pacing to confirm that the true eccentric retrograde activation, and how you exclude the AV nodal conduction with the bystander activation, like this patient have the 2 tachycardia? Thank you.
Sorry, pardon? One more time. No.
Yeah, I see this patient have a 2 tachycardia, and at the first during ventricle pacing, did you perform like a differential pacing to confirm that this is a true eccentric retrograde activation, that is true accessory pathway, or like a pseudo eccentric VA conduction?
Before the first ablation, there was only 2 acopies and the AVNRT was not induced. Only through the accessory pathway, there was the eccentric atrial activations to the left lateral accessory pathway. So we did the first ablation to the accessory pathway at the left lateral.
So we induce only the first conceal AV or T at first, right? Not the AV or T at the same time. Oh, got it. Thank you.
Can you show the slide, the overdrive pacing?
Hi, Professor Kim.
Yes, yeah. I'm Kim Min Kim from Gangbuk Samsung Hospital. PPI minus TCL, please. Okay, so actually, in this case, the importance is the describing the AV NRT with the bystander eccentric pathway, lateral pathway, or as you presented, the dual tachycardia. So in the pre-entrainment pacing, we reset, please. We reset. I'm sorry. Okay, so in this case, his refractory PVC advanced the next day. But in this case, I think that the very important and another information is in the next V interval, really whether changed or not, because in bystander case, next V cannot be advanced. But if this tachycardia really, if this tachycardia is really AVRT, this reset can advance, and next ventricular activation. So VV interval checking the whether the VV interval is constant or changed is may give us an important finding.
Why don't you measure the squid using the caliper? Go right.
The next bit was same as the before the
Yes, I think that the next VV interval is not changed. So in this case, maybe I think that this information gives us the eccentric activation is a clue of the bystander pressure. Maybe.
But I have a question to Dr.
Yes.
Yeah. Because the RR interval is dependent on the AH interval. So this patient has a slow pathway. Sometimes even during tachycardia, the AH interval changes. So how can we include this kind of information? I don't think that just measuring the narrow QRS-RR interval, sometimes we may mislead our interpretation. How do you think?
Yeah, I totally agree with you. So, and in that case, I also performed the his refractory AV simultaneous pacing, premature pacing, can terminate tachycardia, or his PAC deliver in the eccentric, in this case, Halo 1, 2. Whether can terminate tachycardia or not has also give us another information. So I totally agree with you.
Thank you.
Thank you.
Dr. Chandra, no more discussion.
Yeah, no question.
Dr. Chandra, this is hip hop. You.
Yeah, bro.
Do you see this kind of double tachycardia often?
No, I just saw that the first time.
It is quite often to see the slow path AV nodal physiology in patient with accessory pathway because the slow pathway integrate the AV nodal conduction, prolong the AV conduction time and the longer excitable gap in the vulnerable to generating the sustained AVRT. But the simultaneous AVRT and AV node reentry is not that common. It happens quite often, but not that common. I have a question to Dr. Chandra.
Yep.
We know the guidelines doesn't allow to use AV node blocker in patient with WPW syndrome because AV node conduction, the delay of block by beta blocker, calcium channel blocker, reduce the electrotonic conduction and the accessory pathway conduction could be facilitated and the higher chance of pre-excited atrial fibrillation, right?
Yeah.
Yeah, but in this case, I wonder we didn't see any AV node reentry tachycardia before ablating the left lateral bypass trap. So I didn't see any report regarding this issue, but I wonder after eliminating the left lateral accessory pathway, electrotonic conduction to AV node by V pacing during V pacing. In other words, VA AV node conduction was facilitated by ablating the left lateral accessory pathway. This is my hypothesis. And how do you think?
Yeah, bro. In here we saw only like this case like eccentric accessory pathway, and the uplet is gone, and sometimes have a dual adenal physiology but not inducible. The case that I see in Cambodia.
I think we can invite Dr. Chen Huang to listen his experience.
Can we go back to your first slide? Let's do that. So keep going. Keep going. Okay, so this is a 37-year-old guy, male patient, who had a possible history of tachycardia 3 years ago. And then he had a recurrence 1 month prior to presentation. I don't know how frequent it is, only one time, or maybe having weekly, I don't know. Anyway, he's a normal heart, that's what it said. Chest X-ray, EKG X-ray, please. Yes, X-ray shows no really anything serious. EKG shows any other abnormality that you're concerned? Not much. Probably normal access, normal PR, everything normal. Okay. Next slide. One thing that you did not mention is this gentleman PR interval normal to you? Look at the EKG again. This PR is normal? Kind of tended to be short. What do you say? Do you see PR segment in this guy? You don't? Not clear PR segment. PR is kind of a P and T QRS complex. Okay. Next, please. So you got tachycardia here. What do you see here? Do we see any evidence of retrograde P wave anywhere? Anyone see it? Please say so. And then tell me what it is.
Probably in V5.
V5, what do you see? That long, you think?
A little bump.
I'm not sure that's a little bump, but you should be able to see much more clear in limb lead, right? Because a unipolar lead is very difficult to see P waves. So maybe ABF just at the bottom of a T wave, maybe?
Yeah.
That guy? Maybe. But I don't see in 2-3 and ABF. 2-3, I don't see anything really clear cut.
Yeah,
Maybe
so-
lead one. Yeah, lead one right after the QRS complex. Very small. Yeah. Okay. So normally when we say that RP interval more than 80 milliseconds suggestive of a, pathway, but it's kind of go between two. Okay, next slide. Just making a comment. Okay, so you did a DP study. Okay. All right. So you did not have a tracing of baseline here. Now, I want you to look at it. No, stay there. Go back. Yes. We talked about this before. If you thinking doing SVT study, why do you have to pace right bundle? Can you tell me that? RV? Is it RV pacing right bundle branch block? Help you? Right bundle fascicle? Help you or make it more confusing? What do you think? If you pacing left side pathway. So this is a typical example. What happened here? You had a premature beat, sinus follow premature beat, had a long jump, and then you have RV34 have a small sharp potential. You see that? Very teeny guy. Yes, that's the right bundle. Activated. And then tachycardia came back up. Which one is earlier? Retrograde A. Tell me. First beat. You think that's early? How about he say? 1, 2. Yeah. Isn't that early? Right? Yeah, it is early. So how you can say this is eccentric activation? So what does that mean? This already tell you there's a 2 retrograde atrial activation in this patient already. So you should look at the tracing very carefully. So one impulse went up to the septally because you activate the right bundle quickly. And then the other went to the eccentric activation H1 to 3. Okay? But look at the next bit, what happened? So septally got a little longer now. Go to his, yeah. A little bit longer. So you have a fluctuation of what? HA or VA interval between septal and the left lateral is competing already. So you already say, wow, this cannot be only one tachycardia. You already have a conclusion here. Okay? You already should notice that right up front. Because you simply cannot have a septal A activation variation. Somebody have a single loop reentrant tachycardia. Because it has to be consistent. Go to the next slide. Keep going. So here, what did you do? V extra stimulus, you advance the A. Okay? If you measure HH interval here, I think it's the same. My eyeballing. If you measure coupler 2 H interval, 2 preceding complex, and then measure H between that and then PVC following that. I think it looks the same size to me. I could be wrong, but I think I suggest you measure. Okay? That would be very helpful because his bundle activation is going to be only common antegrade conduction in this patient. All right? And then also, if you look at again, after the PVC, there's a slight V activation changes coming going. So look at the next slide. This is just B pacing, okay? So you do B pacing. No, go back there. So B pacing, what happened with the V activation during the tachycardia? Look at his channel. His channel is important in this one. Even though you're pacing right bundle, your VA interval got longer. During the tachycardia is shorter. So how do you explain this? Again, there's a fusion going on, 2 tachycardia here, okay? Because if you're pacing and the VA conduction through the same pathway, doesn't matter where you pace, your VA interval, HAH interval should be the same. That's a sensible orthodromic AVNRT or AVRT, whatever you call it. So I think having 2 different activation timing during the pacing, non-pacing, a little bit about concern, suspicious here. Okay? And then also, if you look carefully during the B pacing, what happened with the VA interval? Fluctuate, change, is not steady, same. Because your pacing cycle is the same. But if you look at the first capture beat and the third capture beat, look at the CS-EGM, slightly shorter. And CS-EGM changes a little bit more. So if you look at the third pace complex, take a look at the HREGM. Is it not the same? So yeah, that guy is different than first 2. And then shorter slightly. So this is something that should give you a clue already also. Okay? So there's many evidence here is that the patient has a double tachycardia, probably. You just have to find the answer. So go to the next slide. There's many things to learn in this slide. Very, very beautiful case. But I think, unfortunately, we don't have time. Keep going. So here you're pacing, and then again, and then what happened? VA time got longer and then suddenly got shorter when you stop pacing. Okay? And even though it gave you a V response, yes, it's a reentrant tachycardia. But then you cannot exclude the possibility based on this AVNRT with the bystander pathway. Okay? All right, keep going. And here, I think is the same story. You be extra stimulus, a little bit of variation, but not too much. Keep going. There's one last slide I want to make a comment. Keep going. Okay, just so I can go back there for 1 minute. One previous slide. Okay, not this one. Keep going. There's one slide that, okay. Tachycardia, the same. Okay, that same thing. Keep going. It's still good. Okay, keep going. Forward, please. Okay, forward. Oh, go back there for a second, the beat pacing. I think that also is important for you guys to understand. If you look at here, your beat pacing shows a gradual fusion between septal to the pathway, right? But if you look at the first two bit, our pacing, that's a fusion because your CS, C, proximal, distal all lines up. That would not be normal, is it? We expect to see more eccentric if you're going through the His bundle, the His A then CS activation. So when you see this fusion bit is also suspect and then gradually merging to the left side, the longer VA interval. Okay, all right, keep going. Okay, that sounds good. Okay, keep going. And then so that's okay, VFP, okay, keep going. So if you look at this slide here, during the V extra, take a look at it. Your septal activation, this is clearly septal, right? First complex is 600 millisecond. CS activation, take a look at it, how they look. That should be normal VA conduction in this patient, right? Not like you saw before, distal CS, proximal all line up. And then finally pathway blocks, AB slow pathway blocks, and then go through the auxiliary pathway. So you can look at the His timing clearly later. Okay, all good, keep going. I have one quick question there, one more slide there. Keep going. Keep going. Okay, let's see. No, not this one. I think you showed it earlier, maybe. Yeah, this is AB node Winkelbach pattern. Okay, keep going. You had okay, keep going. You had a lot of slides. Okay, this one. No, go back there. Yeah, this one. So you paste 2 bit, or you just normal tachycardia going on. Is the tachycardia going on? Right?
Yeah, string
Okay.
cardia, yes.
During the tachycardia. So you have 2 different group of PA conduction or rhetoric activation, timing wise. Second beat and the last beat. Right?
Yes.
Second beat, last beat. And what's the difference here? Why the rate got suddenly increased? 2 different age interval. That means you thought that one went down to the fast, the other went to slow. That's what you're referring to?
Yes, using the 2 different pathways.
Okay. And that's simply because antidermic conduction through the AH one was fast, one was slow. So your measurement measures is basically 133, 135. The other one is 233. Okay. Now, is that would affect your right bundle potential? You think? If you look at the RV, there's a small right bundle potential at proximal, almost every single bit.
Yes.
Hmm?
Yes.
Did they affect that? And faster or shorter, you think? This is important one because of this will tell you which is active, which is a passive bystander. This basically shows that the right bundle activation is consistently earlier. That means septal activation is faster. So it would favor for AV node reentry, not auxiliary pathway. Is a double tachycardia going on? Yes, but you have to differentiate which one is active, which one is passive. Okay. So I want you to look at your CS EGM H12. If you look at the CS H12, when the VA conduction is longer, VA timing is slightly shorter. When you get shorter coupling to the fast pathway, your VA interval in CS get longer, the opposite. Make sense? Do you see it? Second, no, before that one. Go to that guy. Come down CS H12, H1 and 2. Yeah.
Yeah.
Yes. And then you measure the next one is a shorter HA. VA timing is shorter, right? And the last one, VA timing get longer again. Right. So that is basically telling you that this is not because the right bundle potential that exists in preceding all this, probably nodal, maybe not reentry. rather than pathway. Okay? Okay. So I think I made a comment before. This really, when you're thinking about doing SBT case, really does not help you pacing right bundle. It creates only confusion. I wonder if you pace the base of the heart, would it make a difference in this patient? I think it would be. You would be much more clear activation sequence and then retrograde timing activation so you can differentiate easily AVNRT versus AVRT. Okay? So I probably, again, recommend you guys read The Pacing Maneuver by Dr. Melvin Scheiman, wrote it many years ago. It is an important concept. Basal pacing versus septal pacing or apical pacing differentiation, so forth. Okay? But I think regardless, I think a patient needs to be ablated both. Yes, I think so. I agree with your ablation strategy. I think you've done well. Good job. Okay? That's all I have.
During the mapping, we thought the three possible interpretation. Number one is two different tachycardia, double tachycardia, accessory pathway plus AV node reentry. Number two, AV node reentry and the accessory pathway is just bystander. Number three is your paper, the JAC in 1998, the left side slow pathway sometimes looks like left lateral, left posterolateral bypass tract. So that's why we put the coronary vein mapping for VPC. Can you show us during ablation? Yeah. So if you look at the yeah, we put the decapolar catheter to the lateral, the coronary vein, and we try to ablate the accessory pathway during LV pacing.
Sure.
Instead of outflow tract and apical pacing. So
Right.
is there some different and additional information can we get by LV pacing?
Yeah, I think two issues that LV pacing certainly you're favoring to the pathway conduction. That still would not exclude the possibility a patient have double tachycardia because you're going to advance it. Question is that how do you reset or whether HH interval vary or so on. So I think if you paced right ventricular base, LV pacing, I think it would be much more clear view rather than pacing right bundle. Okay? And I do recommend certainly everyone to put the ablation catheter or cardiac vein pacing and or some, sort of a left ventricular pacing before you suspect to have an AVRT from left side. But I think a baseline study, not pacing right bundle, would be crucial important information to delay the right ventricular activation and then take a look at see what happening with the pathway. Would see much better. Either regardless, I think Dr. Gimin mentioned that if you pace simultaneously A and B, even late coupled, I would say, even before the bundle, the tachycardia will terminate. That's if the AVRT is a clinical one. But on the other hand, AVNRT is a driving one, then you're not terminating. Yeah, AVNRT doesn't really buzz, doesn't care what it does. Okay? So I think those are simple maneuvers that you can think about it. But your cardiac vein pacing I saw is a beautiful one, except I think your output may be too high. I saw your picture. I don't know what the pacing output was, but and then I recommend also pace not too close to CS electrode, probably somewhere 3, 4, maybe 1, 2 even would do the job. Okay? Try use a low output so you can see nicer electrogram. Show us your pacing, CS pacing. I saw your huge spike, right? So you can tell whether your activation sequence at this point, V and A clearly, but I think output too high, distal and proximal. I mean, 3, 4 is pretty much a saturated signal. So you don't need to pace that high output because you got beautiful location. Okay.
Dr. Wang, actually the chronic venous pacing is quite useful in my practice, but always I have curiosity. It is valid because it is epicardial pacing far away from the endocardial, the Purkinje system. So,
right.
Is there something to consider when we do the epicardial pacing during the basic EP study?
If you if you look at your epicardial pacing you mentioned, actually a pathway is somewhat epicardial structure. If you look at Becker's histologic studies, many the early days, they are basically just underneath the AV junction, annular junction, and most toward the epicardial. Annular itself is intact. They don't have any defective annulus or anything like that. So if this fiber should be close to the coronary sinus muscle. And the only trouble that I see time to time that this muscle epicardium of fat tissue and then also atrial muscle thickness. For example, left anterolateral wall with appendage muscle is thicker in annular area. When the pathway insert there is very difficult to ablate, difficult to see pathway potential. It will tend to be quite broad. Similarly, when they insert the ligament marshal. The other hand, if just simple left lateral pathway, it's just going to be right underneath the coronary sinus. But the reason you don't see the potential many times in coronary sinus because there's a surround by the coronary sinus fat tissue and fabric tissue to the annulus. So that's the reason I don't see. So, but if you put your pacing catheter down to the cardiac vein, you already, as you mentioned, is epicardial. So I think you should do favor for the pathway conduction. I shouldn't see any concern there because you're not going to alter the outcome or result of the pacing. Except I think you want to pace very low output. The reason is you don't want to patch wide the area of the LV lateral wall because you're interested to know where the pathway is. So you don't want to far field capture anything like that. So you need to be careful. Just pace as low output as possible. That would be more discreet, nicer electrogram. Okay.
Thank you.
If you look at your CS activation right now, your pacing catheter, assuming 1, 2, 3, 4, 5, 6, 7, 9, 10, right? So take a look at your EGM in 3, 4, and then also EGM 7 and 8. I mean, 3, 4, you don't see much A. 5, 6, you have a split, okay? And then you have 5, 6, and 7 and 8, probably the way the split out. So 1 is a negative, 5, 6, 7 and 8 is a positive. P wave, yeah, right there. So you know that the impulse spreading right through there bidirectionally. And then you draw the line there, find out which A in the CS would be better. I think your CS is, as you said, the cardiac vein, all of them is late, not early. But then what you draw a line there. So you know that the pathway is going to be more front, not the back. Okay, that's another way to look at this because you have to remember that your CS catheter is perpendicular to the coronary sinus. Orientation of pacing. Okay, you're going down to the cardiac vein, and coronary sinus is perpendicular parallel to the annulus. So I think it is a different way to look at the information where the pathway might be. That'd be very useful, I think. Okay.
Dr. Daeun Kim?
Okay, no more questions? Comments? It's time to close the session. Thank you for joining us. Thank you. See you 1 month later.
Thank you so much for the wonderful
Thank you.
conference. You guys have a good day. Thank you, bye. Bye-bye.
그렇습니다. 레코딩 스탑.